Good afternoon, everyone. We're going to get started here this afternoon. This is the speech and language pathology session. We have three very distinguished speech language pathologists from our area here, from Henry Ford, University of Michigan and Beaumont. I'm going to present to you some of the techniques and the ideas and the theories behind speech and language pathology treatment approaches. And our first speaker today is Karen Kluin, who is a certified and licensed speech pathologist. She's the senior supervisor in the Department of Speech and Language Pathology and clinical assistant professor in the Department of Neurology, University of Michigan Health System, Ann Arbor, of course. She's also board certified in neurogenic communication disorders by the National Association. She has a special interest and expertise in neurogenic disorders, cognitive communication, swallowing disorders, especially in Parkinson's. And she is now involved in a study with deep brain stimulation and the outcomes in speech-language pathology. So we're very happy this afternoon to have Karen with us. Karen.
Thank you very much, and I'd like to thank Dr. Merson for the invitation to be part of this nice symposium today and allow me to work with colleagues from Henry Ford and from Beaumont. So it's a pleasure for me to be here. And I'd like to start by just giving you an overview of what we mean by successful communication. It involves using, having the motor act of speaking, moving your lips, your tongue. It involves the programming and sequencing of individual speech sounds into words. It involves the language aspect, picking the right words, putting the words into grammatically correct sentences, and it reflects your ability to recall information, integrate information. When you have a breakdown in one or more of those processes, you have a distinct communication impairment. And today I'd like to just focus on the motor act of speaking right now and then move on to the other areas. So let's start with normal speech production. It involves the rapid and smooth fine motor movements of the speech mechanism, and that includes the head and neck, the face and lips, jaw, tongue, the palate, and the phonatory respiratory system. Normal motor speech involves the sequencing of these motor speech processes of breathing, voicing, pronunciation or articulation, and the rate and melody of one's speech. A disorder of the motor act of speaking, or dysarthria, it's due to a central nervous system or peripheral system dysfunction, results in slowness, weakness, incoordination, or change in the tone of the speech musculature. This includes the disorders of respiration, voicing, resonance or nasality, articulation, and prosody of neurological origin. I'd like you to just go over the examination one would perform when you would see a speech pathologist. And for me, my first part involves walking into the waiting room and picking up the patient or the individual that I'm scheduled to see so that I can see how they get up from the chair. I look at their facial expression. And as I'm walking them into my office, I'm assessing their ability to walk and talk at the same time. Once I get a good history, I always ask when was the time of their last medication dose. Are you feeling on? Are you feeling off? If they have a DBS system, I always ask if their DBS system is on or when it was last programmed. I also ask specifically if they've found that the medication helps their motor speech production or any of their other symptoms. Also, just to go over, and then once I obtain that information, I do a cranial nerve exam. I have them perform what are called the alternate motion rates and sequential motion rates, or pa, ta, ka, padaka, and then I listen to their speech. In Parkinson's disease, as you know, there's disturbed control of the speech mechanism, reduced range of motion, paucity of movement, slowness of movement, rigidity, and tremor. The characteristic features of Parkinson's disease, as are listed on the slide, can alter motor speech production and result in dysarthria. And the specific type of dysarthria is hypokinetic dysarthria. And you heard Dr. Merson talk about that this morning, those of you in the session earlier. What I'd like to do now is go over some of the common deviant dimensions that you hear in hypokinetic dysarthria. And I'd like to start with respiration. That's breath support. And in Parkinson's disease, breath support can be diminished. Phonation, the prominent feature is hypophonia or low volume. But one of the characteristic features of hypokinetic dysarthria is that when you tell the person to speak more loudly, they can. And that's different than other forms of hypophonia. 1 second, sorry. Other forms of hypophonia, you're not able to increase your volume on command, such as if you have lesions in both thalamus or in the subcortical white matter. So that's an important feature. Articulation, the prominent features are imprecise sounds or phonemes, especially during what's perceived as the rapid rate of speaking. And occasionally you might hear repetition of words and phrases or palallalia. The prosody, or the speaking rate, often consists of short rushes of speech, increased rate over time, and decreased stress patterns. The goal of dysarthria treatment is to improve the voice, the volume and quality, improve speech clarity, or the intelligibility, via use of dysarthria strategies, or when appropriate, the LSVT Loud program. So I did say that rigidity is often, you can explain the speech problems by rigidity possibly. However, new studies are showing that rigidity is not often the major cause of the speech movement disorder. And neuropathological mechanisms underlining the dysarthria in Parkinson's disease may really involve higher level motor dysfunction and sensory processing abnormalities. Specifically, there might be abnormal non-dopaminergic or special dopaminergic mechanisms which impair the internal self-monitoring or cueing system, causing poor regulation and control of the speech movement, such as the initiation, the amplitude, and the timing. So what I'd like to do now is, how much? I have 5 minutes? Yeah. So 10 minutes? Okay. What I'd like to do now is to call a person in the audience to come up so that I could do a brief examination so that you could see exactly what I do when I evaluate patients. And I'd like to have Dr. Inskeep come up. Smile. Oh, thank you. Can you smile? Good. Relax. Fill your cheeks with air. Don't let me pop. Perfect. Pucker up like you're going to give them all a kiss. Good. Now smile. Good. And then I'll test lip strength by having your lips tightly closed and resist my attempts to open their mouth. And then the next is to look at the jaw movement. So open your mouth real wide. Don't let me close it. Bite down. Good. And then I always test, which I won't do here, is for a reflex called the jaw jerk, because that gives me useful information. I next proceed on to assessing tongue movement. So I will have the person open their mouth real wide, and I just look at the tongue at rest. I'm looking for symmetry of the tongue, any twitches or moving, any tremors. Then I have the person stick out their tongue. Thank you. Don't let me push it. Looking at strength by distance. Stick out your tongue. Don't let me push it. Lateral tongue strength. And now I'd like you to open your mouth wide. Put your tongue to your upper lip, behind your upper front teeth. Good. And now put it down and normally say N.
N.
Real loud.
N.
And L.
L.
Nice. And now stick out your tongue and move it from side to side.
Can you explain why you're having to say N and L?
Yes, because N and L, it's an elevation. You're putting your tongue in the same place. So essentially, I'm looking at the face, the speech mechanism at rest, and then during voluntary movements, and then during speech. So we've looked at the face at rest, during movements, jaw at rest, tongue at rest, now during movement, and now I'm looking at different functions of the tongue tip movement, and that's going to be important in just a few minutes, okay? The next step will be to go open up, and I look at the soft palate, say ah, again, good, nice. And then I will test a gag. And the gag gives me useful information about the integrity of the cranial nerves that are involved in speaking and in swallowing. The next thing I have the person do is take a breath of air in, let it out slowly. Pretend this is a match, blow it out. Good. And now take a nice deep breath of air in and say, ah. And then I might have them do it again to see if we can sustain it for a longer period of time. So that's the cranial nerve part of it. Now I'm going on to the oral diakinetic rate section, which is, I'm going to start with a lip movement, pa. And I'm going to count how many times the person can say pa, 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 over and over again. I'm looking at bilateral lip movement. Ready, go. Stop. Good. So you heard that there was a decline in volume over time. There was a decline in articulation over time. It told me that he could get a good pa initially, but it declined. And that's one of the characteristic features of a hypokinetic dysarthria. Now let's look at tongue tip movement. Ta, 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 ta. Go. Stop. Perfect. And now we'll go on to the back of the tongue, soft palate movement. Ka, 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 ka. Go. Okay. And then we're going to do padaka, padaka, padaka. Put all three sounds together. Ready, go.
Padaka, 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 padaka.
Perfect. Okay. And now what I'd like everybody in the room to do is to sit up straight, because we're going to do a little padakas together. So I want everyone to take a nice breath of air in, and padaka, padaka, padaka. Stop. Everybody had normal padakas. I count how many padakas people do in 5 seconds. I count how many puz, tuz, and cuz. It's a way to objectify so that when I see people over time, I can see if there's been an increase or decrease in their scores. Thank you so much. Great job. Okay. So again, here are the basic strategies that I focus on. Sitting upright, like I just had you do. Take a breath of air in prior to speaking, and speak more loudly, because remember I said one of the features of a hypokinetic dysarthria that you see in Parkinson's disease is the ability to increase your volume on command. The key is to speak slowly, pause frequently, limit the number of words you say per breath. So don't say 10, 12 words, say only 3 or 4 and pause more frequently. And the key is also to make sure you say all the sounds in the word, especially the final sounds, so you're stopping one word before you go on to the next word. Some of the challenges. Well, as we heard earlier today, executive functions can be compromised in people who have Parkinson's disease. And one of the major features is an impairment in your internal self-monitoring and cueing system. So even though the person knows exactly that they should be taking a breath of air in, speaking more slowly, speaking more loudly, they need an external cue to get them to do it. And so, and in Parkinson's disease, this executive function of being able to monitor what you're doing and initiate is diminished. As a result, I've changed the way my approach to dysarthria treatment in Parkinson's disease. I think that it's really important for people to be aware that there is this need for external cueing. And so I don't expect the individual to use the dysarthria strategies 100% of the time, but I do expect them to use the strategies 100% of the time once they've been giving a gentle reminder or a cue that people are not understanding them. A cue would be people leaning in towards you, a quizzical look on your face, or, huh? And then the person should immediately start using their strategies. Any questions? I'm going to move on. My examination also focuses on language assessment, so I always look at the person's fluency, the number of words they say per phrase, their grammar skills, their ability to repeat, do oral reading, the ability to name pictures of nouns and verbs, their ability to answer responsive naming questions such as, what do you put a letter in and a stamp on? As well as their ability to recall words in a group, and I always use animal naming. I assess comprehension of spoken language, reading comprehension, and writing, because writing gives me an indication of their language skills, but also their motor skills, because that's one thing that I monitor over time, the size of the handwriting and the legibility. So I'm just going to go through swallowing very quickly, and that it's divided into 3 phases: oral, preparatory, and oral phase, pharyngeal phase, esophageal phase. And I'll let you just look at these quickly because I'm going to focus on the strategies that we use to facilitate swallowing abilities. These are some of the signs of an abnormal swallow: weight loss, drooling, inability to clear the food from your mouth, a wet, gurgly voice quality, coughing or choking. The one thing that I did want to focus on is that pain with swallowing, heartburn, reflux. Those all require medical assessment. And so the goal in swallowing is to facilitate via compensatory strategies, if needed, a modification of the diet, or when appropriate, expository muscle strength training. And I brought a breather with me today so if people wanted to look at it to see as a device that might be helpful in improving breath support, laryngeal control, pharyngeal strength. And these are the basic swallowing strategies that I always suggest: sitting upright, bringing the food or liquid up to your mouth. Don't bend your head down. When you bend your head down, you're getting into an abnormal position, which makes you at higher risk for things to go the wrong way. I suggest that you always start a meal by taking a drink of water prior to. Take smaller bites and sips. I'm having motor planning problems. I'm always hitting the wrong button. You want to swallow everything in your mouth before the next bite or sip. Avoid tipping your head back. All those Coke commercials where everyone's guzzling, no one should do that. But if you have Parkinson's disease, you really should not do that. Alternate liquid solids, swallows, and eat and drink more slowly. And you see there's a theme here, because some of the same principles apply to speaking and to swallowing. Specifically, small bites, small sips, shorter phrases, don't pause more frequently. Slow when you're speaking, slow when you're eating and drinking. Let's see, swallow twice again if necessary. Don't try and talk and swallow at the same time. And time your medicine to get the maximum benefit from it. Even if you don't think the medicine helps, it's still a good idea to make sure you take it and allow yourself to get on before you eat. And then these are also important. Minimize distractions during meals to allow you to focus on safe swallowing. Shut the TV off, shut the radio off. Don't have multiple people talking to you at one time. Again, it's that doing two things at one time is what people with Parkinson's disease have trouble with. Walking, talking, listening to the TV, radio, and eating at the same time. Those are two activities that dual tasking is really important. And you want to maintain good oral hygiene, brush your teeth after every meal. And then just for you to see, I won't go over them, but these are just basic strategies to help you swallow medication. And evaluation is really part of an evaluation by a speech pathologist is very important in people with Parkinson's disease. I tend to see them every couple months and at least once a year. And I individualize the recommendations today. I just made up a whole list of things that I possibly could, but the point of an evaluation is to make sure you get individualized recommendations and strategies for your specific needs. And because sometimes people are still driving, I suggest that they carry a card that says that they have Parkinson's disease, they have a speech disorder from the Parkinson's disease, so should they be stopped by the police won't think that you've been drinking. It's usually on the back of my card, and then I write down the neurologist. I see a lot of Dr. Chu's patients, so his name is frequently there. And then I suggest a family member's name as well. Okay? I kind of rushed. I was kind of rapid rate myself. Sorry. Any questions? Yes? Oh, I know that's hard. I think that you're going to have people around you make a special effort to allow you to talk. I think that you're going to have to plant like a friend or a family member and heighten their awareness that they're going to have to interrupt and turn towards you and say, and your thoughts, and give you time. Do you guys have anything else?
Just want to remind our speakers, who we so appreciate being here, we do have to finish at 5 till.
Yeah.
We started.
Okay, so was told,
I'm gonna try
I'm just the volunteer, but we have to finish at 5 till. So just want to remind you.
Is this on? No, I think we continue, oh wait, sorry.
Our next speaker is Dr. Alice Silbergleit, and she is the Director of Speech Language Sciences and Disorders in the Department of Neurology at Henry Ford Medical Center, and she is an Assistant Clinical Professor in the Department of Neurology, Wayne State University, and she has expertise in neurologic disorders and conducting research in that area, and we're glad that she's here as well.
How do I get it so that it's only the big slide? Can you hear me? Okay, great. Thank you so much, Karen. You know, I just wanted to piggyback on one thing about taking water before you start a meal. A lot of my patients say they have to drink a sip of water before they take their medicine, that really helps their pills go down too, to just take a sip of water. So I'm going to talk to you about ways to speak louder. How many of you have heard about LSVT Loud? I guess I should say how many have not heard of it. Okay, good, there are a few. So I'm going to, where's that? Here we go. Okay, so I will be talking to you, I'm LSVT certified, so is Dr. Konnai, my colleague, and many of our staff at Henry Ford Hospital. And it's a technique that we use with patients to increase their vocal volume. That's the only goal of LSVT. It does not specifically target articulation, although sometimes there are carryover effects of improved articulatory skills, but the entire focus is to be loud. There's 20 years of research on LSVT, and Dr. Konnai is going to talk to you about some of her research that we're doing with some other aspects of LSVT. But I wanted to go through just a few things. 60 to 80% of Parkinson patients do develop speech problems. Sorry, I can't take this. Okay. Can you hear me? Whoops. Okay. So we know that there's a 2 to 4 dB reduced loudness. Normal conversational loudness is about 70 decibels. Frequently, Parkinson patients get very low, sometimes into the 60 decibel range. We measure it on a sound level meter in a quiet office. So if someone's only at 60 dB, you know, in a quiet environment, imagine how much difficulty they have getting loud in a restaurant or at a party like someone just talked about. So we also know, as Karen said, that there's harshness and breathiness and sometimes vocal tremor with PD. And I think you've already been through this with my colleagues about the speech characteristics and a reduction in sensory perception and self-monitoring skills, so that it does require sometimes someone to say, hey, what did you say? And so with LSVT, which was this big research team that originally did the studies out of University of Colorado in Boulder and had many funded studies, the target is simply to increase volume, because we only want to focus on one thing and one thing only, and have patients or individuals not even think about anything else. So we want to kind of remove that self-monitoring load on them and just know all I have to do is talk loud. That is the entire focus. So we don't target breath support, we don't target articulation, we are only speaking loud, and the rest kind of comes with it. So it's high intensity, and it's therapy that is, we have patients open their mouth. I'm actually going to do a little bit with you, so you'll see it. It's 4 days a week for 4 weeks. And sometimes that's all an individual has to hear to say, I'm out of here. I can't come to you 4 days a week for 4 weeks. But we have actually done telemedicine with Parkinson patients who can't get out of their house or they're in rural Michigan. And as long as we are licensed in Michigan and we see patients in Michigan, we can do Skype therapy with them. And we've done some of that with individuals. So we go through the exact same thing, give them the exact same feedback. It's usually 50 to 60 minutes a session, and there's homework every single night because you have to practice it. If you don't practice it, you're not going to remember it. So it's a very intensive program. And then there's a little bit of maintenance. In other words, we recommend when you're done with the 16 sessions that you don't just forget about it, that you go home and you continue to practice at least once a day so that you constantly have that memory and that skill with you about how to get loud. So we're addressing the sensory problem of reduced feedback so that you're just thinking one thing. And the internal cueing and the neuropsychological issues, we're not even considering that. This is purely loud therapy. So who's the willing volunteer? Okay, come on up. So the first thing I'm going to do is have this gentleman who is Paul. Nice to meet you, Paul. Thank you for volunteering. Have a seat. So I would have gone through the exact same oral motor examination that Karen talked about. And now, when I ask someone to sustain sound, I'm going to measure how long they can sustain sound. So I'm just going to have Paul sustain sound for as long as he can. And that would be for the evaluation. But for therapy, we sustain sound for 15 trials. So, sustain sound for as loud as you can. It's not a shout. We don't want you going to 100 dB. We want it to be kind of controlled loudness. So, ah. Ah is the sound. So you're going to take a breath in. I would also have a sound level meter in front of him so that he can see how loud he is getting. And so we want a consistent loudness. We want it to be loud, and over time, let's say he's 60 dB to start, maybe our goal is, well, at least 75 dB. And sometimes it might be 75 dB on a sustained ah, but drop to 60 dB during conversation. So that's something that this is a hierarchical therapy program. We start off with an ah 15 times. Then we glide into a high pitch 15 times because we want to increase vocal flexibility. Patients with Parkinson's, as you know, become monotone. We want to improve vocal flexibility and frequency range. So we try high-pitched trials 15 times, then low-pitched trials 15 times, I'll demonstrate. And then the person themselves makes up 10 functional phrases. If they're working, it can be work-related. If it's something they do every day, volunteer, it could be something like, honey, let's go out to dinner. I had to fire a coworker today. Or whatever it is, they say those same 10 sentences 5 times in a row. And then we have some conversation, maybe some reading, but the ultimate is conversation. And we measure how loud they are for all of those tasks. And the research has shown that in the clinic setting, when patients come back a year or 2 years later, they have maintained the volume that they have striven for. Dr. Konnai is going to talk about maintaining that volume outside of the clinic. That's one of the criticisms of LSVT, is that that's great when you're in a quiet environment. How does that carry over when you're outside the environment? So we'll talk about that also. Okay, are you ready to give us the loudest, longest ah you can? Okay, great. So, all right, ready? Big breath in. Go. Nice. Really good. So that was, the mic helped. I know. So that is actually another option, to have vocal amplification with you. That is something people can do also to increase their volume. So 15 seconds, that's really good. The classic amount of time for someone to be able to sustain sound is 18 to 21 seconds. So that's very, very good. If you did 15, that's awesome. Now, what we would do is have a sound level meter a 1.5 feet from his mouth. It's the same place, the same distance at every single session, so it's always consistent. Now try it gliding. And we measure how high pitched they can go with an orchestral tuner. Try that. Good, now go low pitch. We would do 15 of those. We would do 15 ahs, 15 high pitch. Get real low. That is fabulous. You got a nice range. Do you sing? Do you sing? Yeah, you're our poster patient. You don't sing. Okay, so we would do 15 low pitches, and we would cue patients, just like that. And we demonstrate and really get animated with them. And then we would go on to the sentences. And then I just want to say that sometimes, because we know as we get older, our vocal cords tend to bow. They're not straight like they used to be. Sometimes they get kind of like this on both sides, and that adds to vocal reduction and loudness. And sometimes, even after patients go through LSVT therapy, we may partner with our ENT physicians, and they can do an injection in the vocal cord to add a little bulk to it. And when that happens, you typically can get a little bit louder with that also. So we would do both LSVT, and sometimes if a patient feels like they're still a little breathy, like a little breathiness is still there, sometimes a vocal injection is also a treatment for to get vocally loud. Does anyone have any questions? Thank you very much. Thank you.
Our final speaker will be Dr. Ramya Konnai, also a speech pathologist, research speech pathologist in the Department of Neurology, Henry Ford Medical Center, and she has significant expertise in voice and the neurologic disorders, and she's going to talk to us about a project she's working on called vibrotactile feedback in phonation.
Thank you, Dr. Merson, and thank you everyone for coming today and giving me this opportunity. How many of you have had therapy, voice therapy? Very nice. I'm going to ask you a very difficult question. How many of you thought it didn't help? It did not help. Okay, one in the room, very brave. Thank you. So, therapy sometimes does not work for everybody, okay, because it really requires discipline. After you graduate from voice therapy, you still have to practice, and not many of us have the discipline to do that. That does not necessarily mean that therapy does not work. It's the use it or lose it phenomenon, right? So you stop doing it, then it stops working for you. And sometimes it's not a good option for various reasons. It could be like a cognitive decline or real severe dysarthria. Not everybody is a good candidate for therapy. So that brings me to the topic here. There are some devices out there, people keep coming back to me year after year. Is there something else? I've already had LSVT twice, So these are some options. I have to be honest with you and say that some of them are very new in the market and have not been studied enough, okay? But it's the principles that these devices are based on, and really the more patients use it and give us feedback, it's really helpful for us to make changes. So having said that, I don't have any conflict of interest with any of the devices that I'm talking about here. So I'm going to basically talk about 3 devices today. The first one is called the SpeechVive. It basically looks like a hearing aid, as you can see in the picture there. So what it does is it's based on a principle called Lombard effect, which is nothing but, how when you go into a noisy restaurant, you automatically speak up? So it's an internal cue, right? It's based on the same phenomenon. So what it does is the device has an inbuilt accelerometer which can sense your speech. So the moment you start talking, it recognizes that you have started talking, and then what it does is it delivers a speech babble in your ear. Basically, what I mean by speech babble, it's the voice of many people talking at a party. So it's that kind of a multi-speaker babble that you hear, and you automatically speak up, because it's like you have to fight that noise and you speak up. So that's what the principle is based on. So there is a group at Purdue University by Jessica Huber who did this study and found that 26 out of 33 patients were successful in speaking louder by about 2.5 decibels. So as you can imagine, this does not require any PhD right? Or any great training. So it's very simple. You hear some noise in the ear and it makes you speak up. And guess how much they charge for that device? $2,400, okay, and it is not covered by insurance. So here come some of the challenges, right? But, you know, it's something that you explore. So sometimes I tell my patients, go ahead, put headphones, listen to music, and see if it will make you talk louder, you know. So we like to make it cheap, right? Just borrow the techniques and see if it will work for you. So, like I said, so, you know, and you don't need really any training. And then patients with hearing aid can still wear it. So if you wear one hearing aid, you can still wear the device in the other ear. But unfortunately, if you have two hearing aids and you cannot manage without a hearing aid, then you probably will not be able to use this thing. It has also been shown to work in patients who have undergone deep brain stimulation with some speech therapy. And now it doesn't constantly keep giving you the noise. Remember, it only senses when you talk and then it delivers that noise. So when you stop talking, that noise also stops. So it's not annoying, okay? And lastly, if you have real bad speech problems and you only whisper, right, you really don't have a voice, then this device is not going to work for you because the device senses the speech, meaning it senses the vocal cord vibration, right? So in whisper, there is no vocal fold vibration, so it won't help you. It'll only you'll only like whisper louder, and that doesn't really make it any audible. Okay? So the next device, which I have played around a lot with and have used in my research, is called the VOCALOG 2. So it's a very simple and sleek design that you wear on your neck. So, you know, the round portion that you see that goes right below your Adam's apple, and that has an inbuilt accelerometer which will sense the vocal fold vibration and know when you're talking. It does not record your conversation, so I'm not spying into you, right? So it only senses the vibration and then records the intensity at which you're talking. So this device has two purposes mainly. The one primary purpose which I am in love with is that it really allows the clinician to understand how you speak outside in the real world. Because, you know, you come into my clinic and give you the mic and I'm measuring, or, you know, I have these fancy acoustic measurements and I give you the mic and you're sitting up tall, oh, you do, and the wife goes, that's not what he does at home, or that's not how he talks at home. He's doing this for you. So I have, you know, and it might be a good day, it might be a bad day. You might be in the on state, you might be in the off state. So in the clinic, it might not really be a good estimate of what your voice really sounds like. So what I do in my research is I send home patients wearing this device for 3 days nonstop, and it averages the value over the 3 days and gives me a good measure of what your voice is really like, so you can cheat, okay? And then after voice therapy, again, I send you home with this device, and then you measure it, and it tells me exactly whether you have benefited from the treatment and you're really using the loud voice at home or not. Okay, and then I give it to you a month later to see if you have maintained the benefits of the voice therapy every place you go, in the movie theater, in the restaurant, at home, when you're watching TV, you know, all places. So that, from that viewpoint, this device has been very helpful for me to find out if therapy has been helpful or not, for you particularly. The second aspect is it provides vibrotactile feedback. It's like a pager. It kind of buzzes when you talk softer. So it is an external cue, because I find one of my criticisms of the treatment is even after voice therapy, people tell me, I still have to think about it. I still have to think about talking loud. If I don't think enough, I forget that I have to talk loud, right? So what it does, let's say you speak at, you know, your baseline is 65 decibels, and I set the target as 70 decibels. So if you talk below 70 decibels, it's going to buzz on you. Cueing, talk louder. Makes sense? So that's another purpose of this device. I will skip these, you know, for the purposes of time. There are challenges, just like with anything and everything in life, right? One primary disadvantage that I've had in my research so far is people telling me that it is buzzing too frequently, that it can get annoying. Makes sense? So people tend to ignore it over time. So right now, plenty of researchers are looking at what is the optimum frequency feedback. Okay, so how frequently should we give you feedback so you don't ignore it over time, but rather really pay attention to the cue and use the cue to talk louder, right? And then some of the other things, I've had mixed reactions as far as the appearance. Some have asked, is it an artificial larynx or voice box? Some people think it's the dark color. Some people think it's just, a fancy microphone that most of the secretaries wear. So I've had mixed, some people don't even notice it, And so I've had mixed reactions. Some of the other negative things are that the device can sometimes vibrate for sounds other than your speech. It does pick up swallowing sounds or throat clearing sounds. We have found that also. And sometimes it vibrates when even people are not talking. And sometimes if you have a very sensitive neck, people are not very comfortable wearing it. But I tell you, that's been only one patient so far. Most of the others have been able to tolerate it really well. And sometimes if you're doing gardening or bending over, or you have real bad tremors, then the device moves in place. There is nothing that secures the device to the neck. So sometimes it can move and giving me false data. So those are some disadvantages of the device. The next device I'm going to talk about is what is called a SpeechEasyPD. This device called the SpeechEasy was initially designed for people that stutter, because people that stutter speak fast, and people with PD can pick up speed and speak fast, clumping words together, as a result being less clear, right? What the SpeechEasy does, again, it has, it's customized for your ear, so it again fits like a hearing aid. It's really small, so it's worn on one ear, and how it works is there are two things that the device uses. One is it provides delay. When you talk, you don't hear yourself immediately. It's like an echo. You know how you hear your echo? You speak, and then after a fraction of a second, then you hear your voice back. So when you talk, the device, what it does is it creates a slight delay, and you don't hear yourself immediately. So you're like trying to catch up. So it really slows you down because you don't hear yourself quick enough. Makes sense? So that really makes you slow down. So you don't have that many repetitions, in your speech. So that's how it works. It also changes the pitch slightly, not that we would turn males into females or vice versa, just a slight change in pitch by 2 hertz, and the brain gets confused. It thinks someone else is talking along with you. Makes sense? So it really makes you slow down, and hence in turn helps with speech intelligibility. So the SpeechEasy is not a device that will make you talk louder. It's not for volume like the other 2 devices that I talked about. This is mostly for people who speak fast and who have stuttering-like symptoms. So how do you get it? So you have to be evaluated by a speech-language pathologist who have to really find the right settings for you, what kind of a delay works for you and which settings give you the best speech. And there is no obligation to purchase the device. You can come try it. There is a 60-day trial period, and if you don't like it, you can give the device back. We do this testing at Henry Ford. And lastly, I know I'm rushing because people are hinting me in the back, you have 2 minutes, 1 minute. So there are apps also. Like I said, these are really some principles for you to think out, because the SpeechEasy, again, is $1,000+. The VOCALOG is again $1,000, and none of these, unfortunately, are covered by insurances. So, if unless you cannot afford it. So what I like is really try to look for apps. So the iParkinson's app is $100, which uses the same principles as SpeechEasy. Now, I don't have any affiliation with these companies, so I can tell you all this stuff. So, it really gives you the delayed auditory feedback and the frequency altered feedback, the principle which the SpeechEasy uses to slow you down. I think I need that now. And then the Fluency Coach is also the similar, based on the similar principle, but you need it's a free software as well, but you have to be, it has to be on a computer. So it's not like something that you can walk around like your iPhone, the other app, and talk in real life situations. So it does limit you physically. But these are just couple of apps that you can purchase and works well. There are a lot of other free apps, but those are not long enough. So it's only like something that you can briefly try to see if it'll work for you, but it's not it'll run in 5 seconds. So you don't want to keep starting the app every 5 seconds, the free versions. So I'm sorry I rushed through. Any questions? Yes. Why do you have a problem swallowing? Yeah, if you think about it, it's the same muscles for speaking and swallowing. Your lips, your tongue, your pharynx, your soft palate, and also, classic symptom of Parkinson's is what we call silent aspiration. So sometimes you choke and your body doesn't really sense it and you don't cough as a result. So things could be going down the wrong pipe, and as well as weakness in any of the structures can also cause you to choke. What ideally I would recommend is you see a speech pathologist who can do a swallow study with the help of in a radiology department, where we take a video movie of your swallowing and we can see why exactly you're choking and what strategies might help. Karen likes to add here.
That in the very beginning of Parkinson's disease, Lewy bodies are found in the brainstem. And so the swallowing abnormalities are due to Lewy bodies being deposited in different parts of the brain. And in the first Lewy bodies often appear in the brainstem. And before you would have, yes, way before you would have symptoms, exactly.
So it's already happening physiologically before you even get Parkinson's.
Right.
Before you even know it, before you diagnose.
Right, and so that happens even in the substantia nigra. As the cells die, they die even before you get symptoms of Parkinson's disease. And it's just Lewy bodies deposited, right? So it's just a symptom of the Lewy body accumulation causing the degeneration. Mm-hmm.
Did everyone hear that? If you have a swallowing study, if you have trouble swallowing, ask your neurologist for a swallowing study that's done by a speech and language pathologist and a radiologist together. And during the study, we give the patients different forms of barium, sometimes coating a cracker, sometimes in the form of pudding, and of course thin barium. So we try different consistencies. And it's a small amount, and it's less than 5 minutes of radiation. Usually it's around 2 or 3 minutes. And then during the study, we can determine where the swallowing problem lies. And if we know where it lies, we can try compensatory strategies right then and there, have you do it under x-ray so we can see if they're working, and then we can work with you on practicing at home to give you a chance to swallow safely.
Thank you everyone for coming. We really appreciate your time.